Hey guys, welcome to another exciting edition of Talking Retirement. My name is Ken Connolly, your host as always, and we have a great episode for you. We've taken quite a bit of a hiatus due to Medicare annual enrollment, but we are back with a couple of great guests coming up for you. So the first one is Dr. Dean Graziano, a doctor of pharmacy who has a bunch of experience in many different facets of the pharmaceutical industry, so we'll be able to dive through all of those and give you a bunch of his expertise. He is also a newly minted licensed Medicare broker too.
I am newly minted. Thanks,
exciting,
Ken.
right?
Appreciate it.
So the cool thing about Dr. Dean here is that he has worked not only in a big chain pharmacy, but he has also worked in pharmacy research, and he has also worked in the pharmaceutical sector of the long-term care industry. So we're going to be diving through his decades of experience in this podcast and getting his insight on every single facet of the pharmaceutical industry, at least as far as we know.
So. As far as we know, it's true. And it is decades.
Yeah. Long
Which
time,
makes me
right?
sound old, but yeah.
Yeah, so Dean, I appreciate you coming on. I think the first thing we should talk about, because it works through, is just you started your career as a pharmacist in a big box store, well, a supermarket to be precise. So could you tell us a little bit about your experience in that supermarket, being, the community pharmacist within that supermarket?
Yeah, sure, Ken. So when I first started out, it was, okay, where am I going to go with this? And you get an idealistic goal, and I always relate it to It's a Wonderful Life. Mr. Gower was one of my favorite TV shows, and I thought, drugstores like that would be awesome.
To be that local
community guy, giving help. I mean, one of the main reasons I got into pharmacy was to help people, and I figure in a community setting, you give them a lot of information. Back in the day, pharmacists, especially in that day, they were one of the most trusted professions, right? Mm-hmm. People would always go down, they'd call you doctor, whether you're a doctor or not, and they'd come and ask your advice, not just on medications, but even if, say you had your child was sick, you weren't feeling well, hey doc, what can I take? Can I take this? Can I take that? So that was kind of what drove me into pharmacy. So we moved forward. I graduated from pharmacy school. I was working as a tech or a student in the local pharmacy chain. They offered me a job in the grocery store, so I said, sure, why not? So you start out as a staff pharmacist like most people do. And you take pride in kind of what you do and again, helping the people. Mm-hmm. Now, we'll get into a little bit of the challenges of it, depending on how busy the store is, I guess being naive when you first start out, it's always about the bottom line and you got to fill scripts.
Yeah.
Right. So do you have enough time as a pharmacist to really talk to everybody when you're filling prescriptions? Because here's the caveat. If you're in a busy store and say some stores fill, I don't know if this matters to people, but you're saying you're filling 200-300 prescriptions a day. It's a lot of prescriptions. Yeah. Because when you look at them, it's not just putting a pill in a bottle and sticking a label on it. You really have to look at the drug interactions of people. You have to say, hey, is this the right medication for this patient? You're kind of overseeing what the doctor writes.
Yeah, because I know from experience, we talk to a lot of people who say that when you're a pharmacist, you're almost the second line of defense, because a lot of doctors, while they do understand pharmacology and they understand these prescriptions, many times they give a dose that's too big. They don't realize that there's an interaction that they might, maybe your endocrinologist prescribed you one thing and then your pulmonologist prescribed you something else. Well, they don't realize that there's bad interactions between those two, correct?
Perfect, Ken. Yeah, I couldn't have said it better myself. You're managing because people don't go to just one doctor.
Okay.
And in defense of the doctor, they may not know because people don't always tell their doctor what medications they're taking, or they may not remember. And it's hard, right? Names of medications are confusing. Yeah. So they just kind of overlook it, and now the doctor writes a prescription not knowing the patient. He's not doing it purposely. Yeah. But that's another reason why, as a consumer, you should really use the same pharmacy. Yeah. Now with the bigger box chains, their systems, again, I started out when computers just started. Okay. So in the old days, you didn't have a computer that was linked to everywhere. Yeah. You had handwritten profiles.
Which means you
had typewriters. Those people who are young listening to this might not even know what a typewriter, think of a keyboard. Okay. So you had to type a label up. Yeah. So that was in the beginning. So computers were great. Technology helps out a lot.
Because they might even notice interactions that you might not even think of.
Exactly. Because you can you get the updates there's only so much your brain can store.
Yeah, exactly.
I mean, now with experience, you kind of just learn. But in the beginning, when you're first starting out, there's so much you know.
Yeah.
There's so much to know.
That's great.
But getting back to, like you said, as a line of defense with the doctors, I mean, most doctor-pharmacist relationships are great. And when I was young, depending upon the doctor, you knew what doctor would listen to you. Like, again, if you find something that shouldn't have been, you call up the doctor's office and let them know. And some doctors were great with that.
Yeah.
Some doctors would be like, I wrote it, I'm not changing it.
Yeah.
So then you'd have to, well, you don't want to hurt the patient. Your job is to help the patient. I'm telling you, this is not right.
Really?
And most of the time, I'm going to say, 95% of the time, doctors are awesome. And they'll be like, well, yeah, you're right. Thanks for your help. You got those 5% are just...
Little
like
ego
anywhere.
tripping,
Exactly.
Yeah.
And sometimes, as a youngster, I would never push back. Now, with experience, I'm always pushing back. It doesn't matter who they are.
You're like, no, I know what I know.
Exactly. I know what
do.
I know, right.
You said you worked in this supermarket pharmacy setting for about a decade?
About a
say?
decade, yep. About 10 years.
I guess what issues were present, 30 years ago that you noticed were issues that are still present today? I know we talked about short staffing and, focusing on the bottom line over patient care. What exactly did that look like in the belly of the beast?
Yeah, in the belly of the beast, it's a good point. So there are days I'm talking about filling 300 prescriptions. Now, when you're a pharmacy and you're a pharmacist by yourself, you can't do that by yourself. Mm-hmm. You need text and you need people ringing the register in the front.
Yeah.
So a lot of times, because you're looking at the bottom line, for example, and it's a store manager running the whole store. Okay, we're considered a department of that store.
Okay.
If they need help on the front end or they need help elsewhere, they would call down and pull one of your people. Mm-hmm. Now, as the pharmacist, when I got to be pharmacist in charge, you wrote the schedule for people, and I would schedule people based upon how busy it was at certain hours of the day. So one of the biggest problems that I used to face was when they would call down and ask to pull your help. And again, my line was, I'm helping people here.
Yeah.
And I don't want to hurt people. And if I'm overworked and too busy, I can't trust myself not to make a mistake or screw up.
Yeah. And it's interesting because they're like, hey, we need help with the registers or something.
Exactly.
It's like, okay, someone might get their groceries 10 minutes later. That's not the same as someone getting the wrong prescriptions. That's a total level of difference. That's crazy.
That's right, Ken. And that was my biggest issue starting out and probably all through the chain. Now, in the chain, I did bounce around from store to store, and depending upon, it's like anyone, anywhere else, right? Some people are different than others. Some understood.
Yeah.
And you have to develop a relationship with them. Whether you like each other or not, you have to develop a professional relationship and get each other's respect. And that's kind of where, in order to help at least with that part of it. The other issue you talk about with bottom line, we talk about drug costs, which was huge. And drug costs through the years have just, as you can see, escalated. Mm-hmm. So, we're paying for that as a store, even if it's a chain. It may not be my money, but it's money, right? And it comes from the bottom line. So, in order to keep a profit margin of some sort, you have to watch what you dispense and what you keep on the shelf. And inventory control is huge. Okay. That was kind of a challenge.
Running on like that lean operation strategy, but that doesn't necessarily make sense if people just need a drug.
Correct. If somebody comes in and needs it now, they don't want to wait till tomorrow or 2 days from now.
Yeah, it's actually something I've seen a lot with Ozempic and Wegovy is people are going to every pharmacy and they just don't have it, which once your body's on it, I think it's interesting because there's a lot of controversy around it. Obviously it's a drug people need, but I've talked to people who say, I've gone to 5 stores and I'm going to have to drive to Staten Island to pick it up. Once your body's on it, you can't suddenly stop taking it or something like that.
No. Yeah, that's a good point. I mean, those two drugs I have strong feelings on those drugs as well. Now, they were originally developed from a diabetic drug. Yeah. And you may remember, Ozempic was originally a diabetic drug. Yeah, semaglutide. That's what it was for. They found out that one of the side effects is a weight loss, right? Now, in general, if you're a diabetic, a lot of times the doctor will tell you before you take medication is maybe in order to combat it is to lose weight in the first place. Not mega weights, but even 10, 20 pounds.
Yeah.
This drug actually helped you lose weight.
Yeah.
One of the mechanism of action of how it works, right? But you're talking about the drug shortage in it. It really took hold when social media got a hold of it and people were using it for weight loss, which is off-label at the time. It wasn't approved for use in weight loss. So these are healthy people, don't have diabetes, want to lose 10, 15, 20 pounds without exercise.
Yeah, and it takes away from the people who are diabetic
Correct.
who truly got it.
That's why I had a major issue in the beginning with it.
Interesting. Yeah, so no, I appreciate that insight first and foremost. So with these big chain pharmacies, there's been a lot of consolidation. We've also seen that, Rite Aid could potentially go out of business. I know we talked about some new players entering the space, like your Amazons, that kind of thing. What has the consolidation of these pharmacies done to the consumer? Has it just given them less options? Like, what exactly has happened as these places have consolidated and gotten bigger?
You bring that up. That's a good point, Ken. That's the first thing that jumped out to me is, I know we're talking about in capitalism and market, right? It's supply and demand. It's the ability to have choices.
Yeah.
Because that's kind of what keeps the prices low. Well, when you consolidate, you don't have that choice anymore.
Yeah.
So really, that one player who's the big player kind of drives the prices and drives everything.
Yeah.
Because they have the power.
And I've seen in certain cases they have like most favored nations clauses. If you don't know what most favored nations clause is, it's this economic principle that we tell you what price you can set and everyone else can't undercut us. Like we say we have 40% of the market. If you want to deal with us, you can't give anyone else a favorable deal. Have you ever heard of that before?
I haven't, but that's...
Yeah. So it's interesting
I get
to
it.
see.
I don't agree with it, but I get it.
Oh, no.
Yeah.
It's not a good thing by any
It's not a
stretch of the
good thing. It doesn't help
imagination.
anybody.
Yeah. There's also been a lot of like vertical integration where insurance companies are buying these pharmacies and vice versa. I know you're not directly in the big box chain supermarket space anymore. Do you have friends in this space who have had to deal with this? And like, what has their reaction been to it?
Totally. I mean, I've had friends working in the big boxes, and you talked about we talked about Rite Aid possibly going out, or it's just not good. In any level, it's not good because I kind of leading us back into a different realm here, but catching up. So COVID, right? When COVID came, and even going back, pharmacy used to have plenty of pharmacists. You had plenty of people to work. Mm-hmm. Within the last 5 years, especially since COVID, they don't have enough people to staff these pharmacies.
Yeah, we've seen it locally. We have, obviously, we're in Ocean County, New Jersey, one of the more densely older adult populations in the country. People are talking about, I can't get my drugs on weekends. There's a 2 or 3 hour lunch break. And, if you're not able to always travel somewhere, if you're not able to do what you need to do, missing that window might mean I can't go back for 3 or 4 days or something like that. It's crazy to see.
Exactly. And I'm shocked. And it's the big boxes that are having the issue. The Rite Aids and this, they just can't get pharmacists because you can't open a pharmacy without a pharmacist there.
Yeah.
You can open the store, but you can't open the department. Mm-hmm. That's a reg, obviously. And if they don't have enough pharmacists to staff it, then the hours get cut.
Do you think it's a matter of, do you think people are just not trying to become pharmacists now, or they're leaving the industry? Because I've talked to people who have left the nursing field during COVID. They've left, being a doctor. Do you see the same thing with the pharmacists? Like, it's just we're not producing enough of them?
We are producing enough of them, and not enough are going into community pharmacy.
Okay.
Not enough want to go into community pharmacy because of, it's a multitude of reasons. The biggest one probably is if you're going to work for a big box pharmacy, is you're overworked. Okay. Not only are you filling prescriptions, you're also required to give X number of immunizations per day. You're required to make sure the drive-through windows manned. You're required to do multitude. When COVID was there, they had to do the testing for COVID.
Yeah.
Now,
so you might be doing COVID testing 12 hours a day. You can't even focus on that.
And you're the only pharmacist. If you're shorthanded, you may have great techs with you, but even techs they can't get.
Yeah.
You can't hire anybody. So if you're the only person there, How are you supposed to stop filling the prescription, go give somebody a test, then go give somebody an immunization? It's not like you just inject them. When you do an immunization, you have to, again, there's
sit with them, make sure
procedures,
they're
sit with them,
okay.
right. So that pressure that they put on people, especially pharmacists, and you had quotas. I do know from people, they used to give you quotas, and they would affect your pay if you didn't hit this quota. So you're thinking, and I know from a pharmacist's perspective as a student, you're in school, you're thinking, I'm a professional. I'm like a doctor or I'm like a lawyer. But when you're out working in a community, you're not treated like a doctor or a lawyer.
Yeah.
You're treated like, and not to put it down, but you're working on an assembly line.
Yeah. They're like, okay, you're a highly paid assembly line manager.
Exactly.
You're not the community person you wanted to be. And so interestingly enough, I went to school to be a pharmacist when I was younger. I switched to business. All my friends who ended up, yeah, it was funny because when you transfer to business school, you're like, oh, this is so much easier.
Oh,
they're like,
100%.
yeah, they're like,
100%.
they're like, no class on Fridays ever. I'm like, what? But all my friends who ended up staying through with being pharmacists, a lot of them ended up being hospital pharmacists. Do you see that happen a lot where people go to the hospital setting instead? Because it's like you can actually be that caregiver you want it to be.
And it gets to the clinical point
Okay.
where in a community, hospital pharmacy is always much more clinically driven.
Okay.
You can use your clinical knowledge more in a hospital setting than you can in a community setting.
Okay.
And that's just the way it is. I mean, not that you can't use your clinical education in a community setting, but hospital, obviously, for obvious reasons, you have more sick people there. You have IVs there. IVs are definitely different than just filling regular oral medication, pills or liquids. And you have to, more thought goes into it.
Okay.
More interactions. So you do see that.
So you might want to do it purely because it's a more challenging in a good way profession. So, we've talked a lot about consolidation, short staffing. What are some things you would like to see change with that industry before we dive into the next industry to be a part of? But what kind of things what regulations, what changes would you need to see in the community pharmacy industry, short-term, long-term?
Sure. I mean, to address the help situation, right? There are on the books right now laws that if you have X number, if you're filling 100 prescriptions, I forget the exact numbers, but if you're filling 100 prescriptions, and you have one pharmacist, you need 2 techs.
Okay.
It's all driven by how many prescriptions are filled. So that really kind of needs to be, I don't know if you want to say you want to maybe check them out and see if they're accurate still, A, and are they being enforced in the big box stores too?
Yeah.
Because sometimes you're not, the Board of Pharmacy is responsible for catching those in all the states.
Mm-hmm.
They may not, there's only how many inspectors are out there.
Yeah, we find that in pretty much any industry. It's like there's just not enough regulators to go around to check things. And even if they do, it's maybe, they find out and like they fix it just for that day or something. Like I worked in the restaurant industry for a decade. It's obviously a different industry, but, when the health inspector came in, it was different for that day compared to everything else,
Yeah. And the other thing that also happens is the big box stores make enough money where they just pay off the fine. Because they get fined and say, okay.
Yeah, it's a cost of doing business.
It's the cost of doing business.
Which is crazy.
We can't afford to hire another person, which we can afford. We just don't. It affects our bottom line too much, so we won't afford.
Crazy.
Which is insane.
All right, so we just went through big box stores, pros, cons, your inside scoop on that. The next thing we want to talk about is you were actually in pharmaceutical research, correct?
Correct.
So what happened? You left the big box chains because you were
tired
a little jaded?
You get jaded. Very good point. Felt like, all right, a dead end, A. B, the hours in community. I had a young family. If I could make the switch, which sometimes it's hard to make a switch, into the setting, an office setting. Right?
Okay.
So when you work for Big Pharma, you're working 9 to 5. And better, they were Big Pharma. So sometimes the benefits were better. Just the whole 9 yards. And so it was something different. So I said, let me try this. So it was drug safety research, which is a lot of more statistical research. And believe it or not, I started there for a couple of years, and I actually got into a training position as a drug safety manager.
Okay.
So training, what I did was I presented kind of stuff like this. We educated doctors and nurses on drug safety regulations.
Okay.
So we were responsible for training any new hires. You were responsible for keeping records, like an LMS system.
Okay, so you were, when a new drug came out, you were the ones responsible telling doctors, hey, these are the side effects. This is what you could potentially run into. This is
more the other end, where when we did mergers, because again, I worked with a big company, we had a lot of mergers. So whenever you had new hires come in, we would say, this is what we're looking for when you're in the field, when you're doing a study. Because, okay, back up, there's two parts. You have post-marketing and pre-marketing.
Okay.
They call clinical. So during investigational phases, you're still responsible for that drug safety.
Okay.
So before a drug comes to market, when you're forming, one of the things they have to look at is it safe? Is it a safe drug? So we have to gather all the data from the investigators, who are usually nurses or doctors, at certain sites. So we put the form together and say, this is what you have to fill out whenever there's an adverse event. And submit it to us, and that's how we... So you'd have to train them on that. You have to train them on what are the regulations.
Okay.
And these were international companies, so not only did you have to do the FDA regs, you had to do the EMEA regs, the European.
Yeah.
So they have a whole... One thing I will say for big pharma is they have an excellent, especially in drug safety I can speak to, is they have a very good training program.
So they really made sure there's no stone left unturned. The data is accurate. You're actually getting what you need to get, everything.
And probably they do that to cover their butts as well, because, the regulators, you don't want to screw up your safety, because big fines, huge fine.
Yeah. I know when I was studying pharmacy as a youngin', they talked about how it cost about $1.5 billion to get a drug to market.
That's correct.
That seems like such an astronomical number to me. How much what's the testing involved to get to 1.5 billion worth of R&D before a drug hits the market? Like, how is that even possible?
The investigators' sites, right? It's so funny because when they develop prices on medications, it's not so much, you think of putting something together like a car or the materials. The materials don't cost a lot for medications.
Yeah.
They've paid, these sites are all clean and stuff, that costs money. But the investigative sites to run these trials, it starts with a preclinical. Before it even gets to human testing, you do animal testing. That's money.
Yeah.
Right? You have to pay the scientists who are studying the chemical compounds. That's a lot of money to do that. Not pay the scientists. Those guys, I give them a ton of credit. They don't get paid super duper amount of money.
Yeah.
The ones who discover these compounds, these super smart people.
Yeah. So John, our president at NJ Life and Health, he actually was in cancer research, and he was talking about working 70, 80, 90-hour weeks, making like $12 an hour. Yeah. And you think cancer research should be highly paid, but they were making nothing.
These guys are the ones developing the chemicals when these and they get nothing compared to what the company gets.
Which is super sad.
It's super sad. It's not funny. And it's, it gets to the marketing of it, right? Look at these TV commercials that you see. How much money does it cost for marketing? Yeah.
You're paying, the lead from The Sopranos for an MS drug. Correct. That might be a couple million, or the shots.
And that drug costs about $7,000
a month or a year. Yeah.
A month.
Yeah. It's a lot.
It's not cheap. Yeah. But again, is the material itself? No. It's all the research and development, the marketing, all those parts going into it. They're trying to recoup their money. Now, they recoup it over and over. The goal is we used to say, if you can get $1 billion drug, that's like, you're golden.
Yeah.
Viagra was a big one.
Gotcha. Like almost like a paradigm shifting drug.
Correct.
Like
it's a paradigm shifting, and it becomes synonymous with it.
Okay. So, if the researchers aren't getting paid that much money and the stuff doesn't cost that much money to make, again, how does it get to $1.5 billion? Like, to me, it almost seems like they're pumping the numbers to a degree to make it seem like they need to recruit more than they do. Like,
I mean, I don't know behind the scenes, but yes. My opinion is yes. Okay.
Like
how much is enough?
Yeah.
Why can they sell a drug in the U.S.? Why can they sell a drug in Canada for a third of the price they sell the same medication here in the U.S.?
Yeah. I mean, I remember reading a book. I can't remember what it was, but it was essentially, I think it was Rise of the Robots. It's like an automation book. And they talked about how, like, we're just at this point where America is really subsidizing the rest of the world. We're paying for the R&D, we're paying for all this, and everyone else is getting it for dirt cheap because we're the ones who are paying that initial fee. And everyone else is like, okay, cool. We got a new MS drug that's $7,000 a month. Well, it's only $100 in Canada or something like that. It's not fair.
It's actually a very good point. Yeah, we are subsidizing.
So what do you think needs to change? I mean, obviously next year we're seeing Medicare is going to start negotiating drug prices, which is pretty standard for every other country. You know, these companies are making money hand over fist, and they're still pulling away out of state assistance programs. They're pulling out of Medicare programs. They're pulling out all these things. Like, has it just become like a cap thing? Like, we're never going to regulate human greed. We're never going to regulate against shareholder value. What kind of things need to happen at the federal level to make these drug prices go down?
They do need, you do need to put a cap on it. Somehow, I mean, if we get political, I don't want to get political.
Okay.
And not even one party or other, all politics aside.
Yeah.
Okay. You talk about greed. I feel that politics are greed.
Yeah.
Okay. And the problem is you do need to put a cap on it. You do need, and believe me, I'm probably a financial capitalist. I think you deserve whatever you can get. However, when it comes to healthcare, I think it's a different story. I think you really have to care about people, right? It's about the livelihood of people and how much is enough.
It's interesting because in New Jersey, we have this great program called PAD, P-A-A-D.
Right.
And it's been a lifeline for all our clients, for thousands of New Jersey residents. And GSK and Novo Nordisk pulled out of it this past year.
I saw that.
I looked at the numbers. I want to say they each profited several $billions each. The revenue was tens of billions of dollars. To me, it's like, at what point is it enough?
Right.
You know, we're talking about, you know, people on Medicare disability. We're talking about people that are over 65 who are maybe making $20,000, $30,000, $40,000 a year. All of a sudden you throw in that medication that's been free is now $1,500 a year. That's a huge difference. That's food versus medications. It's crazy.
And it's disgusting.
Yeah.
In my opinion, it's disgusting that these companies, and then they hide behind, well, we're philanthropists. Look how much money we give to this. Look how much money. That's a bunch of, it's mirrors, okay?
Yeah.
It's smoke and mirrors. They're hiding behind, why would you pull out of a program that helps 65 and older and low income people?
Yeah.
Why don't you tell people about, just getting back to the more expensive medications that, and I've had patients ask me, where can, I can't afford this med. A lot of these new MABs that we're talking about.
Yeah.
I call them MABs, but all these expensive new genetically developed medications, which are great medications or cancer meds. Why shouldn't they be accessible for everyone? Why they shouldn't be priced out?
Which is interesting because going back to the whole research part of this, a lot of people don't realize a lot of the research is actually federally funded, or it's in college institutions. The research phase in the pharmaceutical sector, and correct me if I'm wrong, is patenting it and making it into a product. Is that correct? Where a lot of the researchers are, I think PrEP was an example where most of the compounds have been synthesized with federal research, but PrEP, the drug itself, the HIV medication, had been created as a way to like patent it and make it as a product. Like the initial idea had been like federally researched.
Yeah, I mean, again, it's a 17-year process to bring a drug to market, roughly. That's what they say. But you do have to trademark that product from day one. A lot of the companies do that. So they patent it on day one, whether it's going to make money for them or not.
Gotcha.
Because for every one that gets to market, there's 10 that failed. And depending on when they decide to pull the plug on it, you're spending money up to point and not getting any return on that.
Okay.
So I will give them that defense. However, they're doing pretty well, these big pharmas, okay?
Yeah.
So they're making money. And you're 100% right with a lot of this research is grant-driven, and it is based in colleges, and they are doing, so they're not really, they're spending money. They know how to play the game, right? They know how to get the money. They know how to use the money to their advantage.
Yeah.
And, it gets to the point that, I hate to say it, but when you have money gets money, right? You know how to play with the money.
Yeah.
And again, which is why, to me, meds like HIV research, cancer research, they should be affordable for everybody. There should never even be an issue
Yeah.
that I can't afford it.
I think PrEP, when it first came out, even though it was very grant driven, it was something like $15,000 a
Yeah,
year.
well,
And it's
still-
like, if we give people PrEP for free, we could, within a generation,
Wipe it
knock out
out.
HIV. Like, that's amazing for everybody. Why wouldn't you want that?
There's a new shot out there now. I said once a year for HIV. Just
Really?
came out.
It's crazy to think 40 years ago that would have been
Yeah.
a pipe
When
dream.
you think of the poor people we lost, like Freddie Mercury, I always think of that with Queen. Like
Yeah.
that generation just missed
Like the treatment.
any of the treatments.
Yeah.
Which is extremely sad.
Yeah. And now you have the thing where if we got this more widely available, HIV, you don't get rid of it, but it's effectively not
But
in
it's
your
effectively
bloodstream.
not right.
Yeah.
It's not an issue anymore.
Crazy. So, we talked about putting a cap. What are some regulations you would see to help? I mean, I guess what
To help bring it under control somewhat,
Yeah.
the pricing. It's really can't. It really starts with the individual companies themselves finding which again, I know as I get older, I'm just very cynical. It's just I don't see it because everybody wants to make money, and they're all. We talk about a movie. It's a family-driven company. A lot of them,
Yeah.
and I just want to make $1 billion. If I make $1 billion, I want to make $2 billion. Well, why?
Yeah.
There's only so many houses and so many things you can own.
Yeah.
Don't you want to make a difference in the world and society and going forward and helping people?
Yeah. I mean,
And you still have your lifestyle and you can still maintain it.
yeah, to me, it's like,
That's where
I
it has to
can't-
change. It has to be a mindset. You
Yeah.
can't really regulate mindsets, unfortunately.
you got to put some sort of cap where it's like, hey,
Yeah.
or, maybe you nationalize certain patents or something like that. I don't know how it would work, but
Yeah. Well, the thing with that is, and we talk about, I know socialized medicine had always come about, and that was funny, talking about Obamacare and all, but remember when we were first talking about socialized medication or socialized healthcare, people were, oh my God, you can't socialize. And I'm one of those guys, like, oh, I don't want the government regulating anything.
Yeah.
However, that actually worked out pretty good, Obamacare. You know what I mean? For people who didn't have health care,
yeah.
they need health care. Everyone should have health care.
Yeah, I agree. I mean, if you lose health care, I think the biggest thing I've noticed taking this job is,
Yeah.
I'm 34. I see people 55, 60, 65. The people who are able to catch things early because they had access to healthcare becomes a totally different story. I got my first colonoscopy yesterday.
Oh, congratulations.
Thank you. Yeah. It was a great day. But
It's actually the best sleep you'll ever have.
oh my God, I slept like a baby.
Propofol is
Yeah.
good. I felt bad about it. I know Michael
Yeah.
Jackson, but that actually stuff is incredible.
It was funny. I went. They injected it in me, and I went, "Is it supposed to hurt?" And they said a little bit. Then
You're out.
you know.
Best sleep ever.
But to me, it's like my grandfather died of colon cancer.
That was smart. You got it done.
Yeah, I mean, I'm 34. It's obviously 10 years ahead of time, but the idea that I was able to get it done
Yeah.
well ahead of time to catch a polyp before it could grow, it's a huge difference of, let's say that I had a polyp, but I luckily didn't. I came back clean. But if I had a polyp and I wait till 45, who knows what the hell is going to happen at that point?
Exactly.
It's a totally different story. God.
Real quick, that leads us to the types of medication that the types of healthcare we're talking about.
Yeah.
Are we proactive or reactive?
Yeah.
Right? Prevention versus reacting after when it's too late.
I think reactive is more profitable for a lot of people, but preventative is probably the long-term play if we want to keep
It's the
costs
better
down.
cost saver.
Yeah,
Yep,
exactly.
100%.
All right, so I think the final piece of this, which is good because we're getting a full play-by-play of the entire
Overview.
pharmacy industry, is you, in the past decade, have owned and operated a pharmacy within a long-term care setting, correct?
That's correct. Started out with a community pharmacy first, my own community pharmacy, and then from there kind of merged into a long-term care pharmacy setting.
Okay, so is it within the facility itself? Do you guys mail to the long-term care
And
facility?
what we do is, so how they work, people may not be too familiar. You have what are called community pharmacies, and then in New Jersey, they don't really designate a long-term care pharmacy, but it's a closed-door pharmacy.
Okay.
So what the difference is where we are now is, and there's quite a few of them out there, they're closed-door pharmacies whereby you get contracts with, we call, long-term care, right? Nursing home, assisted living, rehab centers, two types of rehab centers. You can also do the detox rehab as well as just this rehab from a hospital once you're released, and you go for 2 weeks. So you get contracts with these certain companies. And then when you have the contract with them, you deliver. Whether you deliver, we have our own delivery drivers.
Okay.
You can either hire a courier service, but usually it's a daily delivery. We're open 7 days a week. They're never closed, 365 days a year, and it's 1 to 2 deliveries a day.
So you guys will never open to the public.
Never open to the public.
It's closed door because you have all these contracts, you have all these clients, but they can't walk in. You're sending it directly to their house or their nursing room.
Mostly it's not
be.
house, it's the nursing home
Okay.
themselves or their assisted living.
Okay.
Which the way that they're set up, there's independent living within assisted living, so that they always usually have, whether it's a nurse or an aide on staff, we would deliver it usually to the front door, and then the aides or the nurses would take it and either give it to the patients or residents, I should say, of the facilities.
What kind of challenges have you faced being independent in this space? Because do you have competition with big box stores and everything like that?
Not big box stores, but big box companies.
Okay.
There are companies who are not just statewide, but countrywide. And
is that the pharmacies or the
that's
nursing
the pharmacies.
homes? Okay.
Yeah. And the nursing homes can be independently run. They can be independently owned. But now we see more and more of them being corporate owned.
Where people are buying up large swaths
Correct.
of it. Okay.
Yup. And then they're being run by sometimes hospital conglomerates run their own, buy them. You can have, and they can be in this state and they can be in 10 states. So not only do you have you're competing, trying to get contracts against a corporation, which is, as anyone who's had to try and deal with red tape of corporations, it's not one person. It's not like the old days we go with a handshake. You're the owner. I'm the pharmacy owner.
Yeah.
Listen, here's the contract. Here's what we'll charge you per diem rates. Here's what we charge for this. Here's what we charge for that. What do you think? Here's the service we provide besides the money.
Okay.
Because there's other services that we provide besides dispensing the meds. We also are responsible for helping them with the regulation control, whereby the states come in and oversee what's going on to make sure that they're working right.
Okay.
And there's regulations there. So we check those out with them. You have consultant pharmacists who come in and do that and check and make sure they're abiding by the regulations.
Okay. So for you, it's been, I don't want to say tough. It seems like the business is still open, but you're competing against a company that might have bigger resources to deal with those regulations, to deal with the volume that you have to do, everything like that. And in many cases, I find big corporations are like, I'd rather mess with a big corporation purely because of the partnership aspect. And it's like, oh, we can cut costs across the board for each other.
Yes. I mean, there's also, you're not allowed to do certain things, but big corporations kind of like, in order to get contracts, maybe they have deeper pockets. They can do some more stuff to offer little benefits on the side.
Gotcha.
So to speak.
Some shady things.
That we can't always... we're a little guy, we can't always compete with that kind of stuff. But what you do get from an independent, it's like in the community, you get that customer service feel. Okay, you don't have, like, our facility does not have an answering machine. Our facility, some human being picks up the phone.
That's good.
Right.
Yeah.
So
we've sent a lot of our clients to local pharmacies, and once they do it, they can't go back.
Yeah,
even
it's
if
hard
it costs
to go back.
Even if it costs a couple more bucks,
bucks.
they're like, I can tell this person cares about me.
Exactly. And again, I'm not putting down the pharmacist that works in a community pharmacy or in a big box pharmacy. It's just they're so overworked they can't really give you that.
Yeah. So.
And they're miserable.
Yeah, which is not
and
good.
if they're not happy, they're not happy.
Yeah, they're not working.
Right.
I think we talked about it leading up to this, about how we're running into really a ticking time bomb in the long-term care space. And it's something that we've looked into as well, where a lot of people think they're not going to need it, but they absolutely are going to need it. And we don't really have enough people to take care of it. So have you already started to see this come into effect? And what do you think is going to happen going forward?
It's funny because you do see, I've seen it, right? Because I've been around a little bit and I've seen the different generations. Like, we had my mother-in-law live with me. We have my father, who unfortunately passed away of Alzheimer's, but he was home. I wanted him home as long as we could keep him home, right? And then we ended up having to put him in one of these facilities for the last almost year, and it breaks your heart because when you have a loved one in one of these facilities, and you'll see this, because the way the baby boomer generation is aging. And like I was getting back to the older generation always took care of the elderly, right? Your grandparents.
Yeah.
You just did. You could.
Yeah.
Nowadays, it's so hard with the prices of things. You can't be home to take care of them.
Yeah.
So then you have to reach out. Okay, can we afford to bring somebody in our house? And then, like my mom didn't want anybody in the house, but you have that kind of mentality too, whereby, and I get it. So rather than somebody come in, what do? Now we're getting we have to put them in a facility somewhere.
Gotcha. And it's frustrating for all parties because you obviously don't want to see it happen.
No.
The people themselves don't want to see it happen. It's very emotionally draining for everybody involved. I can't even imagine what it was like when.
Well said. Yeah. It's emotionally draining more than it gets to the financial part too. And then how do you put them in? These homes these places aren't cheap.
No, they're 5, 10, 15 grand a month.
And if you want to protect your wealth and protect your saving that you worked for, you see your father work his whole life, and then you have to get rid of all their assets in order to get him in a facility.
Yeah.
They wouldn't want that. Nobody wants that.
No, it's estate planning is very crucial, very early
Totally.
on.
More so now than ever.
Yeah. So we have this thing where people don't want to go for emotional reasons, for financial reasons, for physical reasons, whatever it may be. But as the population ages and we're not keeping up with the population to take care of them, what do you think is going to happen as time goes on? Is it just going to become more expensive, more inaccessible? Like, what is going to happen?
I think they're going to see, and you've seen it with COVID, is more of a change. If we can get the public payer or the private payer or Medicare to actually pay for more in-home care, I think that's the answer. I don't think the answer really is putting them in a facility. I think if you can get the payers to pay for in-home care of people, I think that really is the future. Yeah,
because most people don't want to leave their house, right?
No,
they're like,
do not want to leave
it's
their
like
house.
given the option of going to a facility or living in their home and having someone come in.
I want to die in my home. That's what you want to do.
Yeah.
And I feel you should have that option to do it.
Yeah. And it's probably more cost effective too.
It totally is more cost. Yeah, because you said it right, Ken, because when you look at the cost of living in these facilities,
it's tens of thousands.
It's tens of thousands of dollars. I mean, it's up to $10,000, $12,000 a month to live in assisted living or a nursing home.
Yeah.
And some are even more than that.
Which is insane.
And the care you get is not the people's fault, but again, we talked about shorthandedness, labor.
One person per 10.
One person per 10. They can't get the care that you can get when you're at home.
Gotcha. And how do you manage these people's pharmaceuticals? They're obviously sick. They can't really take care of themselves. Like, how do you manage drug interactions? How do you make sure they're taking their drugs? How do you make sure it's being effective if you're not dealing with these people?
In a long-term care setting, it's really the facility that has to manage as far as making sure they're taking their meds. What we do, we can see, it's a monthly statin drug that they should be taking every month. They should not have any left, right?
Yeah.
So when the state comes in and states do inspections on these places, they look at things like that.
Like, are there drugs?
Everything's
hanging out?
electronic. Are there drugs hidden somewhere? Are there nowadays we're talking about another advantage, I guess, is technology.
Yeah.
Everything is moving from paper to electronic.
Okay.
So now you have electronic health care. So you can monitor people, even people at home. The doctors can monitor them through a website or a computer.
Okay. I didn't know
and
that.
you can tell that. Yeah, you can actually monitor people's heart rates at home. They don't have to be in the facility.
Okay, interesting.
So it's interesting. So you can. So that's why, to me, I think home care is a way to go. Really,
throw like an Apple Watch on someone, and they can manage everything.
Can manage everything.
Okay. In terms of taking care of people at home, I mean, we probably don't have enough nurses for that right now. Correct. So what kind of do you think we'd have to lower the standards, have a push to have more people be nurses?
I mean, definitely, and you would have to have not necessarily nurses, but aides. It really would be driven by how much the person at home needs. In other words, how sick or how infirmed is that person? Okay. Right? You're going to have different levels because you may get to a level where they do need round-the-clock nursing, whereby you may have like an elderly person who is pretty cognizant and pretty mobile.
Okay.
but just maybe needs a little help sometimes.
Maybe
They
some
don't
help
need
around the
that.
house.
Exactly.
Okay.
You know, cleaning. So you can have more of an aid in that setting. I think you can get more help that way, but again, it gets to how much you're going to pay these people who are giving the help. It's
Yeah.
it's an extremely important job.
Yeah.
So that's the fine line.
I think it's, I guess, kind of a glimpse into our future is Japan's been dealing with this for a while, right?
Correct.
Like
Yes,
they
I was
have
gonna bring that
a
up.
much bigger aging population compared to the amount of people that have been produced. So what kind of stuff have they seen as the decades have gone on?
Their culture is a little different in that they really are family oriented, and
Okay.
they really do take care of the elderly. They I don't want to say they have a different. Well, they do. They have a different approach to the elderly. You know, they respect the elderly a lot,
Yeah.
and they think of them as an active community. And I'm not putting down everybody on our society, but we really have to teach that. You know, you can't look at somebody old and say, they're old. Like,
Yeah. I think it's interesting.
it's a mindset.
Yeah, I think over the past, 50, 60 years, we've gotten used to seniors living on their own. But in most cultures, you have those sandwich families where you're taking care of the kids and the elderly at the same time.
And it's stressful.
Yeah.
It's extremely stressful.
Yeah, it's a lot to
we had
deal
my
with.
mother living with us for 27 years, my mother-in-law.
Really?
Yeah.
That's impressive.
My father-in-law passed in his young, 65 years old.
And took care of
We had her living with us for almost our whole, until she passed a couple of years ago.
Yeah.
And it was, it was stressful. But I grew up, Italian family, it's what you do. You take care.
Yeah, I I have friends who are Indian American, and they talk about like you basically get married, and like a year later, your parents move in, regardless of how old you are. Like you just do it,
I mean, it's not perfect, but you know, again,
I'm sure your kids loved having the grandma around.
Exactly, they did, and
but
that's a good point you bring up, right? Because it's a real closeness with the grandparents.
Yeah, and like they're always home. It's like, hey, we're not gonna be home, but watch the kids. You know? Yeah. So, what kind of changes would you like to see in the industry you're currently in? You are an independent pharmacist in the long-term care setting. What kind of things would you like to see change?
I would like to see more regulations whereby, it's, again, I hate saying more regulations, but kind of driven where it's a level playing field, whereby in pharmacy, because long-term care pharmacy now with assisted living has the added component of a community pharmacy whereby you're getting paid with insurances, where when you're taking in a nursing home setting, which is called Medicare A, pays for it, like long-term care rehab kind of thing.
Yeah.
That's a little different pay scale, I want to say. So it's more challenging from a bottom line perspective to keep independent pharmacies open, and even the bigger pharmacies open.
Yeah, even they're struggling.
So I'd like to see us kind of, again, it's kind of the same struggle you see with the community pharmacy like we were talking about.
Yeah.
It really has to do with the price of medications.
Yeah, it's like once
out of
that
control.
domino falls, maybe everything else will
Exactly.
slowly find itself. Oh, it's good to hear. And then in terms of long-term care, obviously you're dealing with the long-term care pharmacy. What kind of changes would you like to see in the long-term care industry?
Themselves, well, you got to get more people working. You have to, whether they have the regulation, I'm not sure how they monitor the regulation of X number of nurses or LPNs or somebody per resident to help, because they're understaffed like everywhere else. And maybe if they help the regulation, and maybe it can lure more people into the setting, maybe the owners of these facilities, kind of give some incentive to have people work for them and not worry so much about the bottom line.
Gotcha. Because a lot of these people are underpaid too, right?
100%. Yeah. Because again, they're a for-profit organization. Yeah. Most of them.
Yeah. They're like, well, we got to.
And let's cut costs so we can make more money.
Just scary because this is people's lives. We're not talking about, we got to sell more Snickers or something like that.
And you really have to. And the family, if you're going to put a loved one in one of these facilities, you need to take an active part in their care even while they're in the facility.
So they can do a lot of the heavy lifting, but you still have to
still have to oversee it. You have to make sure. Like that's one thing I did learn. Thank God I had when I had to put my dad in one with the pharmacy. Like, because a lot of times they'll just throw people on a set of drugs, even if they don't need them.
And you're like, wait. I know that I'm
and
a
I know my
pharmacist and I
father
know the
was on
health.
very few meds, and I'm like, he's no med and without calling me. You don't give him anything without going by me first.
Yeah.
And even if you're not a pharmacist, you have the right to know that.
Yeah. No, I agree.
You have the right to control anything.
Yeah. Say this person can't take care of himself or herself.
Right.
And,
I need to know
I
everything
need to
you're
know.
doing.
Yeah.
To that.
I don't need you to suddenly throw them on 10 more medications. And then they're like, what the hell's
Exactly.
going on?
And I always tell people that that's one of the most important things you need to do is take an active role.
Gotcha. All right. Well, Dean, it has been amazing having you on the podcast, man. Great insight across all facets of the pharmaceutical industry. So where can people find your pharmacy? I know it's closed door, but where can people find your pharmacy and where can they find you as a Medicare
It's
broker?
in Atlantic. Well, pharmacies in Atlantic Highlands. It's called Reunion RX, and you can find me as a Medicare broker on dgmedicare.com,
Very cool.
and you can email me at dean@dgmedicare.com if you have any questions. I'll be more than happy to help.
Awesome. Well, if you guys ever need any help with Dean, he is an awesome Medicare broker and he brings an amazing array of expertise, as you can see. And we are NJ Life and Health. If you ever need help with Medicare, you can talk to us as well. But Dean, thank you again, my friend. We'll talk to you soon.
My pleasure. Sounds good.